If you look more specifically, go down to one problem, one potential area that we can identify as a problem, but be that readmissions, of potentially avoidable rehospitalizations, it's also quite complicated. Why do people Medicare beneficiaries that come home from the hospital go back? Well, they may be that their primary disease, the reason they were in the hospital for the first place, things get worse. The medication is not effective or not being used effectively. Maybe their condition is dynamic such that it requires frequent changes. They may have other self-management issues. Also, another thing can cause a problem. They can fall, develop a urinary tract infection, develop a skin complication, have painful arthritis, a consequence of something consequent of their osteoporosis. Potentially a medicine that they took could impact their mental state and become delirious. There are many reasons why they might, quote unquote, need to be readmitted. There could be consequences of errors in the transition. Maybe things were omitted that were anticipated that they needed once they got home, but they didn't get it. And maybe there was just a lack of communication. A patient that got a new higher dose of an anticonvulsant medicine on discharge with the idea that needed to be monitored. Maybe the docs thought maybe they were overshooting and needed somebody to make sure that didn't create some side effects. And the same thing could happen for many of our many medications, that surveillance, monitoring needs to occur. And then I think another hidden issue behind rehospitalizations are the issues related to the personal care burden, the custodial care needs of our patients in their homes. When those become overwhelmed, many, our caregivers are really often the hidden patient, and it's when they begin to break and they begin to suffer that things break down. And so these things start to go bad, and for whatever reason, we're not able to marshal the troops to change things. So some of the things that may happen, that there just isn't a clinician available, or we don't have the right clinician available. Maybe the model of care that's being provided is not holistic enough, and it may not be specialized enough in certain instances to change what's happening in the patient's home. Sometimes the provider incentives are misaligned. Our partners, our physician partners, our hospital partners may be in models where the organization of personnel is around revenue generation, and it's not flexible enough to do something that impacts these very fragile situations that require a lot of non-visit-based care coordination, cooperation, and counseling. And it may be an issue of the patient's prognosis and their goals and expectations. One of the other concerns is we do have some patients that have uncurable disease, that they have had the most advanced treatments and interventions for their disease and condition, and in spite of that, they continue to be unstable. Those folks may sometimes benefit from changing their model of care, their goals of care, potentially to more of a palliative approach in some instances. So when we see this fire that we're in, for me, I think that home care, in-home care, offers an escape fire, similar to the experience of that creative smoke jumper who burnt that patch of land in that Man Gulch fire. That when you change the venue of care to the home, things change. You get a better view of what's happening to the patient. Practical things like how they manage their medicines, how they take on disease self-management tasks become more evident. You understand, you break down access barriers. I remember one of the first home visits I did was to a heart failure patient who'd been hospitalized, about a half dozen times, and there was a lot of frustration because, the person, quote unquote, wasn't taking their medicines, wasn't following directions. They had some no-shows to the primary care clinic, but when they were there, they didn't seem to follow the recommendations. And when I saw the patient at home and met the husband, he was very excited to work with me. And look, the patient, it turned out, had some mild dementia and was having trouble remembering what she was being instructed during the hospital and office visits that she was having. And the husband said, my problem has been that I just can't afford to pay for parking. And so I just drop her off and pick her up. I'm never involved in the things. But you meet people on home visits sometimes that you otherwise wouldn't meet when you're taking care of you see the patient differently, and you identify resources. And we went a year with that patient before another hospitalization was needed, just working with the husband and being able to teach him to work with her. The relationships change, and when you get into some of these tough issues that we need to get into to successfully manage the high-risk patients that are driving some of the bad outcomes, we need to talk about goals of care, prognosis, end-of-life care planning. And something changes about the clinician-patient relationship in the patient's home. There's a difference in the power dynamic. People are very grateful. It's an act of humanism. They say, well, you kind of left your turf to see me. And it can have implications for how you discuss some of these issues that absolutely need to be discussed in order for us to be successful in managing the high-risk population. And certainly in the home, we can avoid the potential hazards of hospitalization. There's a whole geriatric literature built on some of the potential negative consequences of confinement in a hospital for elders, everything from their propensity for delirium, skin complications, falls, psychological consequences of confinement. Those are potentially avoided when we are able to care for people at home. Most in-home care models that have been well studied cost less than analogous models of care in facilities, be that infusion services, rehabilitation services, what have you. And it's desired more. People want to be at home. Whether this is for post-acute care or end-of-life care, it's pretty well documented that folks want to be at home. And people, this isn't just older people and people that are that sick. People want to be closer to home. They don't like healthcare facilities and offices and hospitals. They feel often powerless. They feel it's inconvenient. We're seeing a whole industry sprout up of healthcare providers within Walgreens and Walmarts and Targets. There are concierge medical providers that offer in-home care as a bonus because they understand that that's something that their people prefer. People like to be cared for in their home. And a neat thing that's happening is the miniaturization and portability of technology, whether this is diagnostic technology, information technology, is making things that were never possible to be done at home possible. So a lot of the past barriers, logistical barriers, are being opened up. And I think that that we're going to see in the future an ecological shift of where healthcare is provided. And because of these factors, the consumerism, the aging population, the miniaturization and portability of technology, we'll see the home, the patient's home, becoming the primary venue of primary care, chronic care management, post-acute care and rehab, acute care, long-term care, end-of-life care. I think that whether this happens in years or in decades has a lot to do with the politics between the winners and losers and the politics of self-preservation. But if we look at what should happen and where the forces are taking us in terms of the population, the epidemiology, the technology, the consumers, the desires, that this is where we're headed. And in many respects, from a medical standpoint, it's where we started.